topic given me for today is differences and similarity between NASH and alcoholic liver disease. And I'll not be covering alcoholic hepatitis as that is a phenotype which is very unique to ALD, not seen in NAFLD. So I'll be discussing between NAFLD and ALD. So globally, coming to prevalence, NAFLD prevalence has increased by 50% when compared to between 2006 to 2019, from 25% global prevalence in general population to 38%, and global prevalence of NASH is 5.3%. Coming to alcohol consumption, nearly 28% of the people worldwide, 22.3 billion people consume alcohol. And global prevalence of alcohol use disorders is 5.1%, with males having more prevalence. And in general population, ALD prevalence is 3.1%, which increases to above 50% if the alcohol consumption rises further. And detection of ALD in its early stages is very rare compared to other causes of liver diseases, less than 4% versus up to 30% in other causes of liver diseases. So coming to definition of NAFLD, NAFLD is defined as hepatic steatosis in the absence of secondary causes, with alcohol consumption less than 20 gram for women and 30 gram per day for men. But this definition is a definition of exclusion. People may underreport alcohol intake, and the absence of positive criteria is used to define NAFLD. Currently, the new term what everyone is globally using is MAFLD, metabolic dysfunction associated fatty liver disease. This has a positive criteria: any liver fat with at least 2 parameters of metabolic dysregulation out of all the listed there will make them fit into MAFLD. So metabolic risk factors, if more than 2 are present and alcohol consumption is less than the scheduled ones, then it is called metabolic dysfunction associated steatotic liver disease. But if the consumption is above 20 but below the risk level 20 to 50 gram, then it will be MET ALD. If the alcohol consumption is more than 50 gram and more than 60 gram in men, women, then it is called alcoholic liver disease, irrespective of the presence of metabolic risk factors, even if they are present. And after this new definition, the prevalence in large American studies showed the prevalence of ALD to be 3.2% versus 11% for MET ALD and 22.6% for the MAS LD. And of late, after COVID, the alcohol consumption has also gone up by over 25%. So in future, we will be having more patients with ALD and MET ALD. So why ALD? Why we consider it as ALD when a higher alcohol consumption is present is because even though metabolic traits may be present, but the main driver of the liver disease progression in patients with higher alcohol consumption with metabolic traits is only the excess alcohol per se, not the metabolic traits, because it progresses faster due to alcohol. So further. If you can see here, NAFLD population is NAFLD prevalence is 30%, 25% of them will present with NASH, 10% will develop cirrhosis, 1% will develop HCC. Coming to alcohol, again, around 20 to 30% will of heavy drinkers will develop alcoholic fatty liver and alcoholic liver disease, out of which around 35% will develop steatohepatitis, maybe clinical or subclinical, but out of which 15% will end up developing cirrhosis. So almost a similar spectrum over the exposed at-risk patient and developing cirrhosis is only around 10%. And the differences between them are the age of presentation is above 50 years in the NAFLD, around 20 to 45 years in the alcoholic liver disease. Male, in some studies they have shown slightly female preponderance in the fatty liver disease. In alcoholic liver disease, men develop more because men drink more. Otherwise, relative risk is more in women who drink at the equal levels. And initial stages, ALT is seen higher than AST in the fatty liver in NAFLD or MAFLD. But in usually alcoholic liver disease patients do present with an advanced presentation and advanced liver disease. Coming to the histopathological similarities and differences, pericentral large macrovesicular steatosis is the is the feature in finding in both the conditions. There is exacerbated presence of MDB, Mallory-Denk bodies or ballooning degeneration, central sclerosing hyaline necrosis, and central vein phlebosclerosis, cholestasis, presence of intracellular and canaliculaar cholestasis, foamy degeneration, megamitochondria, presence of hemosiderin, hemosiderin inside the hepatocytes, and ductular reaction, chicken wire fibrosis, apoptotic bodies, and cellular infiltrates are more prevalent in alcoholic patients than NAFLD, although it can be seen in NAFLD as well, but the extent is higher in ALD patients. And feature which is more specific to NAFLD is presence of nuclear vacuolization. This feature is more favoring towards presence of NAFLD. Coming to early diagnosis and non-invasive tests, patients with FIB4, elastography, and ELF score. These three are the most commonly used for NAFLD. The more data is available for NAFLD. When FIB4 is less than 1.3, just monitor them once in 2 to 3 years if there is presence of metabolic risk factors. If FIB4 is very high, more than 2.67, then it should be under CLD management. In between intermediate scores, they should undergo a second test beyond FIB4. FIB4, for everyone's sake, it consists of 4 parameters: AST, ALT, age, and platelet count. It is routinely given in our OPD LFT. FIB4 score is written, and that is the first thing what we should be seeing. And after which the elastography, if it is in the intermediate zone, we should do elastography or ELF score. ELF score is also done here, I think around 4.5 K per test. It uses 3 parameters: hyaluronic acid, procollagen 3, N-peptide, and one more thing. And sir, TIMP1, tissue inhibitor of metalloproteinase. TIMP1, these 3 parameters are used, and it costs just 4.5 thousand at our place, and that can be done, or elastography, what fibroscan, what we do, that can be done. The intermediate scores here, if the FIB4 is higher in between, and these are low, then they can be kept on follow-up. If intermediate, then they should be referred for advanced care. Similar tests, all these NITs have been also tested in patients with ALD, although limited data available. Here, patients with a no fibrosis category can be followed up and advised to take less alcohol. But with the intermediate type, score of FIB4 or ELF or LSM, they should be advised to undergo repeat test after 3 months of strict abstinence, unless there are any red flags present. Otherwise, they should be followed with. But very rarely ALD patients present with the early stage or asymptomatic stage. But this is the algorithm that should be followed. The common denominators between the NAFLD and ALD are steatosis, inflammation, and fibrosis in both the conditions. This is pathophysiologically and morphologically there is overlap. Steatosis to inflammation to fibrosis. So, origin of hepatic fat for steatosis in NAFLD is 60% of the fat is from the adipose tissue lipolysis, because the adipose tissue is hypertrophied, stressed, hypoxic, and inflamed because of the macrophages in the adipose tissue or in the inflammatory version, and that leads to altered adipokines, increased leptin, decreased adiponectin, that leads to oxidative stress in the adipose tissue, which leads to increase in the again the macrophages, interleukin 6, TNF alpha. This chronic inflammation in the system will cause insulin resistance, and that leads to increased free fatty acid levels in the circulation. That leads to lipotoxicity. This origin of fat is in 60% of the source. In the liver, de novo synthesis of fat can also happen because of increased gluconeogenesis. Increased insulin will lead to higher SREBPC and carbohydrate response element binding protein. That leads to increased production of fat DNV, de novo lipogenesis in the liver, because the insulin resistance in the liver is last to happen. Peripheral tissues, it will happen first. In the liver, it happens later. So this increase in de novo is more prevalent in the initial stages. And the dietary fat and dietary sucrose is the third source for liver fat in NAFLD. While coming to the alcoholic liver disease, the de novo lipogenesis is the more common source of fat in alcoholic liver disease. That is because the alcohol is metabolized into NADH, and increased NADH will lead to higher fatty acid synthesis. Additionally, acetaldehyde is also effective in decreasing the beta oxidation of fat, and alcohol also to some extent increases the sterol receptor and also causes some adipocyte loss in the periphery, leading to increased free fatty acid influx from the peripheral tissues. That is also seen, but the most common here is the de novo fat synthesis. And progression from steatosis to inflammation, this free fatty acid is toxic to hepatocytes. And whenever it is taken inside, it induces hepatocyte apoptosis both by the intrinsic and extrinsic pathways. It activates the CYP2E1 NADPH oxidase to generate further free radicals, further worsening the presence of reactive oxygen species, and that leads to endoplasmic reticular stress, lysosome injury, and further inflammation perpetuates. The inflammatory mediators from adipose tissue, from liver, from gut, from Kupffer cells, everything will cause chronic hepatic inflammation, leading to a state of hepatic insulin resistance, that further aggravating oxidative stress. So mitochondria has a very important role in both ALD and NAFLD. Mitochondria are both the source and victim of oxidative stress in both the fatty liver diseases. Normally, mitochondrial biogenesis or multiplication or formation of new mitochondria happens when there is increased energy demand. That is by the presence of increased AMP levels, increased ADP to ATP ratio, increased NAD plus to NADH ratio. That stimulates this AMPK and stimulates the PGC1 alpha. That leads to mitochondrial biogenesis, and in addition to controlling of ROS and the inflammatory mediators. In the presence of insulin resistance, this doesn't happen. There is accumulation of damaged mitochondria, which leads to increase in the leakiness in the mitochondria, leading to apoptosis and further perpetuation of the oxidative stress. Thus, mitochondria is both the source and the victim. So normally what happens in the mitochondria, the oxidative phosphorylation from both glycolysis and the fat will produce NADPH or FADH2, that is transported through the electron transport chain. The electron transfers from the higher to lower energy levels, producing ATP, from ADP to ATP. During the process, the protons are exported outside from the inner mitochondrial membrane, that is taken back later. So what happens normally also there is 2% loss of electrons from the mitochondria during this ETC. But what happens when there is excess of NADPH levels or excess of energy inside the mitochondria? That leads to increase in the leak of electrons from the inner mitochondrial membrane. That leads to extra electron carrying oxygen, that is hydroxyl radical, which produces superoxide, which produces hydrogen peroxide, and that leads to the hydroxyl radical, and also nitrogen peroxynitrate radicals. These cause further damage of the membranes, proteins, enzymes, DNA, and everywhere. This electron leak is the major reason for the presence of reactive oxygen species. And further, which leads to mitochondrial outer membrane protein pores or apoptosis inducing factor release from the mitochondria, which causes both apoptosis from the intrinsic and extrinsic pathways. Further, if the inner membrane also gets damaged, the pores in the mitochondrial transition pores they develop, that leads to leakage of all the electrons, the loss of all the voltage gradient between the inner and outer, that leads to total death, mitochondrial death, and inflammation and necrosis. Inner mitochondria leads to necrosis. So this reactive oxygen species inside the mitochondria crosstalks with the endoplasmic reticulum, further perpetuating the development of cellular stress, oxidative stress. So reactive oxygen species is the most important mechanism for cellular injury in both NAFLD and ALD. And next comes the inflammasome. Both in ALD, and this has a major role both in NAFLD and ALD. Inflammasome is a multi-protein complex that is expressed in hepatocytes and myeloid cells, like Kupffer cells. They sense inflammatory signals via NLRs, node-like receptors. Once they sense through the DAMs or PAMs or the bacteria, these NLRs sense the pro-inflammatory signals. So that leads to polymerization of these complexes, NLRP3. This polymerizes and forms the active form, and it activates the pro-caspase. Caspase is the enzyme which cleaves the pro-inflammatory interleukins. So the caspase cleaves the pro-inflammatory to convert them into inflammatory interleukins, IL-1, IL-1 beta. That does it includes it causes inflammation, further perpetuating the. It is called pyroptosis. Inflammasomes cause pyroptosis. There is also involvement of mitochondrial reactive oxygen species here. So there can be two pathways. I will not go into details. This is common in both NAFLD and ALD. Formation of multi-protein complexes and NLRP3. Coming to the further perpetuating the inflammation, the gut microbial changes are seen in both in ALD and NAFLD. Gut dysbiosis is very common in both the conditions. There is gut dysbiosis, bacterial overgrowth, altered intestinal permeability. The effects are signaling from the terminal ileum, leads to further fibrosis and cirrhosis. There is increase in the primary and secondary bile acids, and also there is increase in certain bacteria in both ALD and NAFLD as mentioned here. But things which are particular to NAFLD are there is increase in fecal bile acids. There is the fecal primary to secondary bile acid ratio is increased. Endogenous alcohol production is increased. Trimethylamine oxide is also elevated in the NAFLD patients rather than ALD. Certain bacteria like lactobacillus are increased, bacteroides increased, rheumococcus increased, Prevotella decreased. Whereas here the candida metabolites like beta glucan from the candida is increased, acetaldehyde level is increased in alcohol, decrease in the butyrate, decrease in the long chain fatty acids, decrease in the antimicrobial proteins from the stool, from the intestines, in more so seen in ALD patients. There is decrease in the lactobacillus as compared to NAFLD, and there is increase in the candida albicans in ALD. So one distinguishing feature from NASH to NAFLD, like obese patients and NASH, what differentiates is presence of Escherichia genus. This is accompanied by significant elevation of endogenous ethanol from the intestine to the. So the presence of this particular bacteria increases the alcohol production from the gut itself, and that is taken to the liver, causing further inflammation. So on the top of this, some people are predisposed to develop both NAFLD and alcoholic liver disease. The genetic factors, if you can see here, the most commonly targeted genetic polymorphisms, PNPLA3, transmembrane TM6, SF2, MBOT, A7, superoxide dismutase, TNF alpha. These are common in both NAFLD and ALD pathogenesis. There are certain other polymorphisms which are exclusive to ALD and NAFLD, but these are the most commonly done tests, and as well these are inflicted in both the diseases. In addition, there is upregulation of certain micro RNAs in NAFLD and downregulation of MIR122, which is commonly associated with steatosis and fibrosis. This downregulation is also seen in patients with ALD122, and certain microRNAs are upregulated in ALD. For everyone, microRNA are the ones which regulate the genes, and these are not going to change. They are going to regulate the gene transcription at the DNA level. When certain microRNAs will increase the transcription from certain elements of the DNA. Additionally, there are epigenetic changes which have been noted in particular to NAFLD and ALD. Although limited data, I will not go into detail. But one thing to note is in NAFLD there is increase in methylation, and in ALD there is more of acetylation of the histones, epigenetic changes. So this is what I have spoke so far. I am summarizing in this slide. In NAFLD, from adipose tissue there is inflammation, adipose tissue dysfunction, lipolysis because of insulin resistance, increase of free fatty acids taken up by the liver, leading to lipid accumulation, leading to lipotoxicity. Additionally, there is some changes in the adipokines, increase in leptin resistance, decrease in adiponectin. In alcohol, also there are certain changes in the adipose tissue, but mainly it acts through de novo lipogenesis, increased lipid accumulation, and lipotoxicity due to increased free fatty acids and reactive oxygen species. There is sublethal hepatocyte injury because of the lipotoxicity that leads to mitochondrial dysfunction, increase in oxidative stress, and defective autophagy, mitophagy or cellular autophagy, increasing further perpetuating endoplasmic reticular stress, and certain extracellular vesicles, microvesicles, they also are involved in cross communication locally. All these are common in both ALD and NAFLD. This leads to cell death by apoptosis, ferroptosis, and all the mechanisms, most commonly apoptosis. Through dams and inflammasomes. These dams also activate the hepatic stellate cells, and additionally, before coming to stellate cells, some patients are genetically predisposed to have this inflammatory nature, and also the lifestyle changes like what we eat, what we drink, that leads to dysbiosis, leakage of DAMPs and PAMPs, LPS and PAMPs from the gut, leading to activation of Kupffer cells, NF-kappa B activation, leading to further activation of hepatic stellate cells. There is activation of both adaptive and innate immunity in both the patients of NAFLD and ALD, more so in patients with ALD. Further, all these inflammatory milieu after activation of stellate cells leads to fibrogenesis and disease progression. Certain parameters like decrease in fatty acid oxidation and decrease in lipid catabolism, impaired VLDL secretion, they are more common in NAFLD, and predominant SREBP or carbohydrate response element binding protein, these are more so with ALD. So currently they are using the term panoptosis, pyroptosis, apoptosis, necroptosis, ferroptosis, all included. All are active in both these fatty liver conditions, and especially certain toxic lipid species are also increasingly seen in NAFLD. So what happens in patients with dual etiology, metabolic traits present plus excess alcohol intake or maybe moderate alcohol intake? In these patients who have both the risk factors, they develop impaired lipid handling by both the mechanisms. There is perpetuation of oxidative stress and endoplasmic reticular stress, leading to cell death. And further, there is accelerated fibrosis and disease progression in those who have both the etiologies because of higher inflammatory response due to both the conditions. They are super additive. So with this background, coming to the treatment options, although FDA has recently, I think, has approved the THR beta agonist remisetron for NAFLD, but otherwise there is no approved FDA drug for either conditions, ALD or NAFLD. All these metabolic pathways, what we discussed so far, have been assessed, and majority of them are in phase 2, phase 3 trials, all these pathways. But what I wanted to highlight in this slide was in ALD also, these are potentially applicable, these pathways are involved. These are some like OCA and selenosertib, ASCON inhibitor, they are in phase 1, phase 2 trials. Otherwise, these are the highlighted pathways, PPR, FGF21, FGF19 analogs, anti-chemokine antagonists. These are also ACC inhibitor, acetyl-CoA carboxylase inhibitor, fatty acid synthase inhibitor. These can be effective even in alcoholic liver disease, and some are in early stage trials as well. And on the top, for both the diseases, for NAFLD, like losing 10% of weight is the utmost core of treatment. For ALD, abstinence is the core of treatment. Remaining things are just add-on, and as on today, not much effective. So to summarize, NAFLD and ALD are the leading causes of chronic liver disease globally, with increasing in numbers over the time, and cirrhosis developing in only a fraction of them. ALD affects younger with more severe at presentation, both clinically and histologically. There are many overlapping pathophysiologic like steatosis, inflammation, fibrosis. There are shared genetic and epigenetic factors. Clinical presentations are also similar. There is the term MET-ALD is a new important category. There is no safe drink for patients with metabolic dysfunction, metabolic traits with them. And just food for thought, alcohol may fast forward the fatty liver disease in genetically susceptible and persons with risky lifestyles, because that develops at 50, this develops at 20 to 30, 40. So possibly it fast forwards. So thank you for your attention. I hope